Good afternoon, everybody, and welcome to today's deep dive. And very happy to co-chair this meeting with Charlene Parasnath from UKZN. Welcome, Charlene, and it's great to have you all with us today. So just a few housekeeping things. If we can go to the next slide, please. So the recordings of the talks of every week's deep dive can be found on Blood SA's website. As you can see there are fantastic resources. Really want to encourage everyone to at least go and have a quick look to see what is there. Please contribute to the conversation, not only by speaking. I know it's sometimes not everybody wants to speak up when there's a lot of people in the room, but please feel free to post your questions in the chat box. That would be really great. For South African attendees with MP registration numbers, CPD will be automatically submitted to the Health Professions Council, but it is important that you attend at least 60 minutes. The system automatically counts or calculates the time. So you've got to be in the room for at least 60 minutes. So if there are any other queries or you're from another country, you're welcome to email Melanie Davids, who can assist with certificates of attendance. Next slide, please. So today we've got 3 talks. It's always very lively when we've got more than 2 talks. And it will start with a clinical case presentation by Dr. Joshua Karunakaram, and followed by understanding coagulopathy in acute promyelocytic leukemia. And I remember very well, starting out treating these patients in Bloemfontein, how many patients we lost in the first week from coagulopathy. Patients often came from far. They were diagnosed late. They sometimes came with white cell counts of 200, something unheard of in the Western world. And knowing how to manage this coagulopathy should be considered absolutely essential knowledge for any trainee in clinical hematology. So, and as these sessions on Mondays are specifically directed at our trainees, both the ClinHeme and the HemPath, and with many topics also internal medicine and pediatrics, today's session is really absolute key knowledge. And then we've got management principles of APL, which I see here is Dr. Karunakaram again. Charlene, you can just confirm if that is not yourself. I thought it was you.
No. So hello, everyone. So I'm having a bit of a challenge. I just got home now to realize that our Wi-Fi
will indeed be Charlene.
So I just wanted to introduce our topic today, Van, and if I can you hear me first of all?
Charlene, I'm going to hand over to you in a second to introduce the topips.
Sure, but I just want to know if you can hear me, because I got home to my Wi-Fi not working, so I'm actually speaking off my phone. So I'm hoping they will sort it out. Okay, thanks.
We can hear you and see you. Perfect. Wonderful. Okay, next slide, please. Okay, actually, can I ask you just to take me to the very last slide, and then we'll come back to the speakers. So just for those who attended a little bit, who joined us a little bit later, just to remind everyone, there's no need to fill in any red cap links anymore. CPD points will be automatically submitted to the HPCSA, but you have to stay for a minimum of 60 minutes. Now, with that, I'm very happy to hand over to my co-chair, who will also introduce the topic and the speakers, Dr. Charlene Parasnath. Charlene is a very dear and very valued colleague. She's head of clinical hematology and the stem cell transplant unit at Inkosi Albert Lutuli in Durban. Charlene, always a pleasure to have you. Charlene and the team have been consistent, strong supporters of the deep dive, and they've done a lot of hard work in the last couple of years to present many topics here. and always been very well received. So thank you, Charlene. Over to you, and I'm going to hide my face, and from here on, you can introduce and the speakers can start.
Okay. Thank you, Vanan, for that introduction. And you very correctly said, I mean, many of us actually experience the difficulties of treating coagulopathy in APL patients. And particularly, we chose this topic because Dr. Karuna Karam is actually a new medical officer in our department, and he actually helped manage one of these patients successfully. And hence, I thought I would allow him the opportunity to be part of this platform and see what it's all about. But we had two really sick patients that had a coagulopathy, and it was actually, it is quite a difficult time in the unit, because it does mean that we're using a lot of resources. There's a lot of time that's taken to actually manage these patients. So we decided to do it in form of these two clinical cases, and then Dr. Yadia Miraj will cover the actual basic sciences behind the coagulopathy, and I will do a little bit, it's not very in-depth, but just to touch on important aspects of management in this short time. So without further ado, I will introduce Dr. Joshua Karuna Karam. He's actually a newbie. He's recently completed his community service and has joined us as a medical officer in our unit. And he's been there for less than 2 months, but really has done very well. So I'm happy to introduce Joshua to everybody, and I'll hand over to him. And maybe I should introduce Yadia as well. So Yadia, Dr. Yadia Miraj, she's a hematopathologist, and she joined us as a clinical heme trainee, and she was a recipient of the South African Clinical Hematology BMS Foundation grant. And Yadia also started last year in August, and she has found her feet very well, and very proud of how she's coming along. And so she's very excited to present today. And so I will hand over to Joshua now. Thank you.
Hey, good evening, everyone. I'm Dr. Karuna Karam. I'm just going to try to share my screen. Yeah, I'm not sure. Can everyone see my screen?
Yes, we can, Joshua.
Okay. So as alluded earlier, I'm Dr. Karuna Karam. I'm one of the medical officers in the Department of Clinical Hematology, and I'll be presenting 2 clinical cases on acute promyelocytic leukemia. So the first case is patient NM. He's a 21-year-old African male, RVD non-reactive. He initially presented to Northdale Hospital in Pietermaritzburg on the 4th of January 2023. He gave a history of back pain and constitutional symptoms. This was followed by hematemesis and melena. Thereafter, he had fever and rigors. There was no medical or significant surgical history. There was no use of over-the-counter medication or illicit drug use. However, the patient admitted to traditional herbal medicine use. And on the 4th of January, at that time, at 20:59, his bloods was done and his HB was 8.4, with the platelets of 19, a white cell count of 4.70, and the analyzer differential count, his neutrophils was 74.8%, a lymphocytes of 9.6%, monocytes of 10%, and an INR of 1.53. And his LDH was 632 and a CRP of 259, with a raised GGT of 309. So the smear was reached the NHLS lab and was seen on the 6th of the first month, 2023. The manual differential count, promyelocytes of 64%, blasts of 3%, and the white cell morphology comment showed numerous abnormal promyelocytes. These cells are medium to large in size, where they folded, bilobed, with abundant granular cytoplasm. Some blebs and numerous hour rods and occasional faggot cells. There was also noted cottage-lobed forms and arrest in neutrophil maturation. So the results was communicated with the treating doctor on the 6th of January at 12. The clinical hematologist on call at Nkosi Albert Lithuli was informed of the case. The patient was thereafter referred to clinical hematology at Gray's on the 6th of January. The patient was commenced on Atra at 40 milligrams BD, allopurinol 300 milligrams daily, as well as a FTP daily for 200 mils daily. This was the flow cytometry, and the flow cytometry was in keeping with an acute promyelocytic leukemia showing immature cells. So the immature markers of CD34 negative and CD11 117 HLA-DR. There was 91.22% of immature myeloid cells in keeping with the AML without maturation and with the immunophenotype in keeping with APML. The PCR showed a percentage of greater than 100% of PML RARA able. So at Nkosi Albert Lithuli Central Hospital, the patient was transferred to us on the 10th of January 2023. His clinical examination, so these were his vital signs on arrival. His temperature was 39.9 degrees Celsius. His pulse was 136. His respiratory rate was 21 breaths per minute, a blood pressure of 109/67 millimeters of mercury, and his oxygen saturation was 100% on room air. So general examination of the patient, he was significantly pale. There was no significant lymphadenopathy. There were skin lesions noted and scarification with secondary hemorrhages, so possibly from the traditional healer. There was also a scab over his left epicondyle. On his systemic review, this cardiovascular system, there were normal heart sounds, no murmurs. The patient had a hyperdynamic circulation with palpable thrills over his arteries. The chest was clear. The abdomen was soft, non-tender, no hepatomegaly, no ascites. He was passing good amounts of urine. Central nervous system, no focal neurology, no meningism was noted. So the patient was assessed at the time. The patient was assessed as a high-risk APML based on his full blood count done at Gray's on the preceding day, with a white cell count that was more than 10 and a platelet of 14, with the complications of a bleeding diathesis. A probable neutropenic sepsis as well, because the patient was clinically febrile with a tachycardia. However, the results found from his initial admission at North Hill Hospital showed him to be an intermediate risk. So this was the patient's bloods on his admission at Nkosi Albert Lithuli with a white cell count of 18.21, HB of 4.8, and a platelets of 13 with an INR of 1.25. So the possibility of the increase in the white cell count due to the use of Atra that was started at Gray's. So the plan was to give him 2 units of packed red cells and 1 SDA platelets. Blood cultures were done, PCT was done as well with the urine MC&S. FDP and cryoprecipitate was started based on the results of the coagulation screen, and he was to start daunorubicin the next day. So we started him on dexamethasone 10 milligrams twice daily, and Atrac 40 milligrams twice daily, with hydroxyurea 1 gram twice daily, pantoprazole for the high dose of steroids, and he was started empirically on TAZ and AMIC. So this was his initial chest X-ray on admission. He had a baseline chest X-ray done in view of his sepsis. So the progress on day 3, which was the 13th of January, during the course of the day, it was noted that he had developed a drip site erythema, suspected a drip site sepsis. So in view of that, antibiotics was escalated to imipenem, and as well as he started cloxacillin in view of the drip site sepsis. Acyclovir was also added to the patient's treatment. It was noted that the patient developed hiccups at night, and it was noted by the doctor on the night duty that the patient had just eaten and it had resolved. Overnight, the hiccups persisted, and the patient didn't inform the night staff of this. So this was the chest X-ray that was done on the 13th, and they didn't look much. There wasn't much change from the initial X-ray that he had. So on day 4, which was the 14th of January, the patient's clinical condition changed. So the patient complained of coughing up blood with nosebleeds. And on the 14th, around midday, the patient became distressed with frank hemoptysis and intractable hiccups. Clinically, it was noted that the patient was restless. He had worsening hemoptysis of plus minus 250 mils of blood being coughed up with a significant hematuria. The patient dropped his SATs oxygen saturation to about 84% on a 40% face mask, which he was then changed to 100% rebreather with severe respiratory distress of 50 breaths per minute. The patient was diaphoretic. The chest had good air entry bilaterally with scanty crepitations noted bilaterally. The patient's GCS was 15 out of 15 with no focal neurology. At that point, the assessment was made of a worsening sepsis query, differentiation syndrome versus disseminated intravascular coagulopathy. So the plan in discussion with the consultant on call that day was the patient to be placed on Evo, double strength FDP, increase the cyclic heparin if the urine was normal, change the patient to vancomycin 1 gram twice daily, and we added fluconazole 400 milligrams daily, Ligactil for the hiccups, and to discuss the patient in ICU, as well as order 1 unit of RCC and 1 unit of SDA. So this was the dramatic change in the patient's X-ray on the 14th, showing this diffuse patchy infiltrates that were noted on bilaterally on the chest X-ray, which was very dramatic from the previous X-ray, which was done the day before. So assessed by the consultant, the chest X-ray was worrying for diffuse alveolar hemorrhages. The patient was discussed with ICU and subsequently intubated with rapid sequence induction. The assessment made by ICU was as follows. The patient had pulmonary hemorrhage requiring intubation and ventilation, post-hemoptysis and epistaxis, as well as bilateral patchy infiltrates. Second problem was that the patient had neutropenic sepsis with a tachycardia, and the patient was febrile, a PCT of 4 on admission, which was on a downward trend. Received imipenem 3 days, cloxicillin, acyclovir, and vancomycin currently. Coagulopathy, the patient's platelets was 14, and he was receiving daily RCC and platelet transfusion. So the progress in ICU on the 14th, antibiotics was changed to meropenem due to the multiple temperature spikes that the patient had. The nasogastric tube was only inserted on the 15th when the patient's platelet counts improved. At this point, we considered the ways of administering ATRA or to use arsenic trioxide. However, Section 88 motivation was sent for the arsenic trioxide, but was declined and requiring further motivation. We then looked at other ways of administering ATRA, and the ATRA was given via NGT with olive oil. White cell count was on a downward trend of 0.25. So the ATRA was given 40 milligrams in 10 mils of olive oil via the NG tube twice daily. It was started on the 17th of January. On the 18th of January, the patient was extubated with post-extubation hypertension and temperature spikes. The patient was started on labetalol infusion at 4 mils per hour, and sedation was maintained with propofol. The patient was then changed to oral amlodipine on the 19th of January, and on the 20th of January, he developed a left armpit collection that started to form and was querying a possible abscess. On the 22nd, the patient was now then stepped down to high care and then back to the ward on the 25th of January. So this was his X-ray that was on the 15th when he was being stepped down, rather on the 25th when he was being stepped down to us, to the general ward, and you can see the difference on the X-ray from the 14th. So the progress in the ward, the patient grew Acinetobacter baumannii from the blood culture on the 20th of the first month, and from as well as from on sputum, and it was sensitive to gentamicin. Patient had received 10 days of meropenem and was commenced on colistin on the 23rd. The left axillary abscess formed when there was neutrophil production, and incision and drainage was done on the 31st of January. A bone marrow was performed on the 31st of January, and the patient was discharged on the 31st of January for review in 1 week at our clinic. Post-induction, and the post-induction showed no MRD on FCM. So the second case was patient BN, 36-year-old Indian male RVD non-reactive, referred to Northdale Hospital in Pietermaritzburg on the 1st of February rather. The main complaint was 1 week history of bleeding following a tooth extraction. Reports to having lost 2 liters of blood. The patient had significant palpitations, tiredness, fatigue, and shortness of breath, with subconjunctival hemorrhages of the left eye and difficulty hearing on the left ear. His blood results on the 1st of February showed a HB of 4.1, a platelets of 14, and a white cell count of 7.30. The analyzer showed neutrophils of 2%, lymphocytes of 3%, and other cells of 95%. His coagulation screen was rejected due to the incorrect tube use. On the 2nd of February, consultant on call was made aware of the patient's diagnosis. There was no beds available. The patient was then sent to Gray's Hospital for management. The patient was commenced on ATRA, and his echo showed an ejection fraction of 67%. Blood cultures were done prior to transfer as the patient was pyrexial. On the 8th of February, the patient was accepted at Nkosi Albert Luthuli for admission. On examination, his temperature was 39.5 degrees Celsius. He had an ulcer on his upper lip and on the hard palate. Subconjunctival hemorrhages were noted on the left eye, no pallor lymph nodes, and he had mild pallor and no edema. Systemic exam showed the chest to be clear. Cardiovascularly, he had normal heart sounds, no murmurs. The abdomen was soft, non-tender, no organomegaly. CNS, there was no meningism or signs of focal neurology. However, the patient did have some confusion of note. So the plan on admission was for a COVID swab, a chest X-ray, a CT brain, due to the confusional state as well as the hearing loss and subconjunctival hemorrhages. Antibiotics were started, so tazocin and amikacin, dexamethasone 10 milligrams BD with hydroxyurea 1 gram BD. A proton pump inhibitor was started, FDPs, acyclovir, and we had to await the results, transfuse the patient bloods and platelets, and the patient commenced daunorubicin on the 9th of February. Follow-up PCR results and flow of the bone marrow results. So as noted, there were 2 dual fusion signals were detected in 130, 150, 86% interface cells analyzed, and it showed PML-RARA 22100. The final mRNA PML-RR G6-PDH ratio was determined as 0.009:1. So these were his results from flow cytometry showing 81.36% of abnormal myeloid precursor cells. Then on the 14th of February, the patient reported chest pains, not to be restless, and a D-dimer cardiac enzymes was done. He was also noted to be restless. So as you can see on the ECG, the patient had a sinus tachycardia, Q waves in lead 3 with T wave inversion in lead 3 and S wave in lead 2. So the typical S1, Q3, T3 with clinical features as well. Thereafter, based on this ECG, a CTP angiogram was requested. And the CTPA confirmed small bilateral filling defects with a medial posterior-basal segmental compatible with pulmonary embolism. So the report showed a CTPA demonstrating small bilateral filling defects within the medial posterior basal segmental arteries, compatible with the pulmonary emboli, and no CT features of right heart strain. In addition, there was multilobular ground glass opacification and pulmonary nodules with septal thickening in the left lower lobe. These features were compatible with a pulmonary infection, and we had also done a blood culture which showed Klebsiella pneumoniae, which was sensitive to the treatment that we had the patient on. Based on the CTPA findings, the patient was started on enoxaparin, and the plan was to check the platelets and adjust the dose based on the platelets. Subsequently, the Clexane was stopped due to the patient's low platelet count. This was the patient's ophthalmology review, and it just showed that the patient had a left subconjunctival hemorrhage, and inferior macular subhyaloid hemorrhages as well. So on the 17th of February, the patient complained of severe left lower chest pain and pain in the left upper quadrant rather. Patient was clinically tender. There was decreased air entry on the left lower chest. So then we performed an ultrasound abdomen on the patient in view of the tenderness in the abdomen as well. And it showed a hepatomegaly with features of steatosis and a normal spleen with no lesions. However, the patient continued to complain of severe left upper quadrant pain on the abdomen. The abdomen remained soft, so we opted to do a CT abdomen. And the CT abdomen showed left splenic focus. This is most likely secondary to an old insult with an infarct, a secondary differentiation. He also had left pleural effusion with associated bivasal lung atelectasis, and there was no acute vascular pathology noted. The patient is currently admitted in our ward and being managed. Thank you.
Thank you, Joshua. It was well done for somebody being so new. I don't know if anyone has questions now, whether we should leave it to the end, but I just want to comment the reason was choosing these two, because I can see there were two pathologies, one a patient that bled and another patient that developed thrombi, and these patients actually were quite ill, and we were actually quite happy that the first patient actually survived ICU, and the ICU actually took the patient in the first place, because oftentimes, I'm sure many of you that are working in the state sector, I know Prof. Lowe has spoken about this before, that they have managed to convince the ICU that hematology patients do have hope, but we actually were glad that the first patient was given the benefit of ICU and actually made it through. And then Joshua spoke about the ATRA, and I think last year we spoke about ATRA and using it when a patient has a nasogastric tube. And so we read up about what would be the easiest way to deliver it. And I found one of the guidelines from one of the NHS hospitals, and they suggested the use of olive oil. And we tried to do that. We cut up the capsule. It was quite messy, though, I must say, and quite a task to perform. But we managed to actually give him the ATRA in that time. So that was one challenge. Then with regards to the other patient with the thrombosis, he is a challenge to manage because he's developing these thrombi, but I mean, we have a shortage of platelets, so it's not possible to be, continue transfusing him platelets to a level that's safe enough to give the Clexane. I will talk a little bit about the use of anticoagulation in my talk, so we won't go too much in depth here. But if there's any questions, we are. Diversion asks, thank you for the comprehensive presentation. In terms of morphology, did it favor hypo or hypergranular? So these both were hypergranular, and both patients actually were intermediate risk. But what we did note was that, we gave the detail of the transfer of the patient because the challenges we actually face, and we're just glad that we have Maurice in Grays that has the knowledge to actually institute the treatment. And I think that's one way that we're actually managing to save these patients' lives. So she started the ATRA, and when the patient got to us, the white cell count had gone up. So although these patients were both intermediate risk at presentation, when they got to us, the white cell counts did go up. So I think I will stop here. We will chat a little more later on. Josh, you can stop sharing, and then we'll hand over to Yadia.
Hi, Charlene, can you hear me?
I can hear you, Yadia.
Okay, I'm just gonna share my screen. Okay, is that fine?
Yes, we can see it.
Okay, good afternoon, everybody. I'm Yadia Miraj, and I'm going to be talking about the coagulopathy that we see in acute promyelocytic leukemia. Acute promyelocytic leukemia is a distinct subtype of acute myeloid leukemia, and it is associated with a rapid downhill course characterized by coagulopathy. It accounts for 5 to 8% of the newly diagnosed AML cases. The classification has changed. In the past, we described it as AML M3 or M3 variant. The M3 was the hypergranular or classical APL, and M3 variant is the hypogranular APL. We're now using the WHO classification, and APL is classified as AML with recurrent genetic abnormalities, APL with PML-RARA. APL is a hematological emergency requiring immediate diagnostic confirmation and instituting specific therapeutic measures. Treatment with ACHA or arsenic trioxide alone or in combination with chemotherapy yields a complete remission as high as 85 to 95%. It is critical to success of treatment to treat the coagulopathy. In this diagram, we can see that APL is characterized by the balanced translocation of chromosome 15 and chromosome 17, which leads to the oncofusion protein PML-RARA. This fusion oncoprotein functions to repress RARA and non-RARA target genes. It induces leukemia by blocking normal myeloid differentiation and leads to clonal proliferation of promyelocytes. Both PML and RARA have a role in normal hematopoiesis. PML has growth suppressor and pro-apoptotic activity, and RARA functions as a transcription factor that mediates the effect of retinoic acid, which is necessary for normal myeloid maturation. Long-term survival outcomes for APL are now higher than any other acute leukemia. For patients who survive the first 30 days, more than 90% will be cured. Death within the first 30 days after diagnosis remains the most common cause of treatment failure. The complications associated with coagulopathy can either be bleeding or thrombosis. The most common organs involved in bleeding are the brain, lungs, GIT, and mucosa. Intracranial hemorrhage is the most common cause of early death. The first 4 days after therapy is the highest risk period for early death and hemorrhagic complications. Clinical CNS hemorrhage was shown to be an independent risk factor for later CNS relapse. Venous and arterial thrombosis can occur in up to 20% of patients with APL. Common thrombotic events include deep vein thrombosis, pulmonary embolism, myocardial infarction, and ischemic cerebrovascular events. Microvascular thrombosis, a major feature of DIC that manifests clinically as skin necrosis and multi-organ failure, has rarely been reported in APL. The increased risk of both hemorrhagic and thrombotic complications in APL highlights the unique mechanisms that govern the coagulopathy. The coagulopathy in APL is caused directly or indirectly by the leukemic cells through expression of activators of coagulation and fibrinolysis, and proteases and cytokine production. It is also compounded by a failure of platelet production due to marrow invasion. At presentation, the predominating feature is usually hyperfibrinolysis. So how do we make the diagnosis of APL? Usually it's by morphology. That's the first thing. And then we confirm the diagnosis with other specialized tests. So on morphology, we saw in our patient a hypergranular APL or a classic APL. And in the top right-hand picture, you can see the bundles of our rods, which we refer to as faggot cells. And here the arrows are showing us single our rods. And in the last picture, we see a typical APL cell, which has heavy granulation, which is eosinophilic, and bilobed or cottage-shaped nucleus. In the top right-hand corner, we see what we refer to as the hypogranular variant. And you can hardly see any granules. It's fine or almost none present in the cytoplasm, but still a similar nucleus, which is bilobed or cottage-shaped. In the flow cytometry, there are differences between the M3 and M3 variant. This is the typical APL because you can see that the side scatter is quite high due to the complexity, and this is due to the heavy granulation. In the M3 variant, the blasts would lie in the blast window, which is lower down here. But in this case, it's very high side scatter. So usually in APL, the MPO will be positive, CD45, CD33, CD13, CD117, and CD64 will all be positive, and HLA-DR will be negative. A subset of the population may be CD2, CD34, and CD56 positive, which can confer poor prognosis. Granulocytic markers are usually negative. And what's interesting is CD9 can be helpful in determining the difference on flow cytometry between a hypergranular and a hypogranular APL, because in a hypergranular APL, you may see a homogeneous bright expression of CD9, whereas in the M3 variant, it would be dim and heterogeneous. You can see that this is the flow cytometry of our patient that Joshua already discussed. And 96% of the population was CD9 positive. And in the next case, 95% was CD9 positive. So then on, after morphology, we go on to more specialized testing, and cytogenetics determines karyotype, and later it's helpful in determination of response to treatment and for assessing genetic evolution. Quantitative PCR in FISH is important to diagnose variants and to find other prognosticating factors such as NPM1 and FLT3 internal tandem duplication gene mutations. 1% of patients may lack the characteristic translocation 1517, referred to as a variant translocation, and this is the case where RARA is joined to alternative fusion partners. This has an implication on choice of therapy and prognosis. So in this diagram, we can see that on the PML gene, we have 3 breakpoint cluster regions, 1, 2, and 3. Breakpoint cluster region 3 is a short isoform that confers a poor prognosis. This table is showing us the other 1% of fusion partners that RARA may have. So the most common is translocation 1117, but there are a list of others like translocation 1517 and derivative 17 and 417 and so on and so forth. But we can see that some of them are poorly responsive to ATRA and arsenic trioxide. So a patient with APL may present in the following ways. They may have pallor due to anemia, signs of bleeding and infections, fatigue, swollen gums, mild fever, a discomfort in bones and joints, weight and/or appetite loss, enlarged liver, spleen, or CNS symptoms. In terms of laboratory findings, they may have a thrombocytopenia, and this thrombocytopenia doesn't necessarily predict their risk of bleeding. They can have a prolonged PT and PTT, which also doesn't necessarily show you the whole picture of the coagulopathy. They may have elevated D-dimers, low fibrinogen levels, and abnormalities on TEG. TEG is still a research tool, investigational tool at this point for APL, and is not done routinely in practice. But what one may see is a prolonged R interval and a shortened alpha angle and a shortened MA. So at diagnosis before treatment, we can risk classify a patient according to the SANS score based on their white cell count and their platelets. We have 3 categories: low, intermediate, and high, and this will depend on whether the white cell count is less than 10 or more than 10. So what are some of the high-risk features we see in APL? Well, clinically, a poor performance status less than 2 is one, and the others are mostly lab parameters: an elevated white cell count of more than 10, low fibrinogen levels, increased fibrin degradation products, a low platelet count, elevated creatinine, the presence of FLT3 internal tandem duplication, CD2 positivity or CD56 positivity, as well as BCR3 isoform of the PML-RARA transcript. Cytogenetics is also important because you might be able to identify a complex karyotype. Other abnormalities that might be seen in about 40% of patients is a trisomy 8 or deletion 7q or deletion 9q. So in order to understand what goes wrong, it's important to just revise the normal coagulation cascade. And the newest model is the cellular based model, which is based on initiation, amplification, and propagation. And then we have the classical coagulation pathway, which divides things into the extrinsic and intrinsic pathway. So just to explain the normal, I'm going to use this diagram because I think it explains things quite well. But we start with tissue damage or endothelial injury, where we have tissue factor exposed and binding factor 7, which gives us tissue factor and activated 7A, converging to the common pathway and giving us factor 10. We also have contact factors with factor 12 giving us 12A, which then gives us 11 and 11A, and 9 giving us 9A, also converging on the common pathway. Prothrombin is then converted into thrombin, and then we have fibrinogen, which is converted to fibrin, and then we have our fibrinolytic pathway. But thrombin does a whole lot of things. It also activates factor 13. It also initiates the intrinsic pathway, and it causes activated for factor 13 to give us a very stable fibrin clot, which can only be broken down by plasmin. Now, in APL, what's really important is the fibrinolysis part of the cascade, because this is where things go very wrong. And we can see plasminogen is converted to plasmin via tissue plasminogen activator and urokinase plasminogen activator. And the inhibitors, which are the broken lines, alpha-2 antiplasmin and plasminogen activated 1, in much lower concentration compared to the activators. So in this diagram, we can see in diagram A what's normal, and in diagram B what happens with APL, which I will discuss a little bit further. But in diagram C, we can see that with the help of ATRA, or the treatment of ATRA, everything that goes wrong, all pathology can be suppressed by the use of ATRA. And this is important for things like cancer procoagulant and annexin 2, which are all suppressed and downregulated with the use of ATRA. So the main mechanisms of hemorrhage in APL is that the fibrinolytic system, which is responsible for clot breakdown, and mostly plasmin is involved. So following thrombin generation, fibrinogen is cleaved to fibrin, which then polymerizes to form an insoluble fibrin clot, followed by factor 13 cross-linkage and a stable clot. Plasminogen is activated by tissue plasminogen activator and urokinase plasminogen activator to generate plasmin. Plasmin cleaves fibrinogen and fibrin, resulting in degradation products. We then have a hypofibrinogenemia. Annexin A2 is a cell surface receptor for TPA and plasminogen, which is overexpressed in APL. As we said, ATRA works quite significantly on the downregulation of annexin A2. It is perhaps the most important fibrinolytic activator expressed by APL cells. Annexin A2 increases TPA-dependent plasmin generation up to 60-fold, and thus has a central role in promoting fibrinolysis. It has been hypothesized that increased expression of annexin A2 on cerebral endothelial cells may contribute to the high incidence of intracranial hemorrhage in APL. Plasminogen activators are inhibited by plasminogen activator inhibitor 1 and thrombin activatable fibrinolysis inhibitor, or TAFI. These factors control fibrinolysis. Plasmin then binds, inactivates, and is inactivated by alpha-2 antiplasmin. Reduced levels of alpha-2 antiplasmin lead to further hyperfibrinolysis. Neutrophil extracellular traps, or nets as we call them, cause vascular leakage by damaging the integrity of endothelial cells. Primary hyperfibrinolysis is independent of thrombin generation. Secondary fibrinolysis is increased due to thrombin generation, which stimulates the endothelial cells to produce TPA. Systemic breakdown of clots and microvascular clotting or lysis typically seen in DIC. An abnormal elastase and activation of matrix metalloproteases contributes to the fibrinolytic activity and degradation of fibrinolytic inhibitors. What may be of importance in the future or have a potential therapeutic role is recombinant tissue factor pathway inhibitor, because this could decrease the active coagulation. The thrombocytopenia also to some extent causes hemorrhage. There's also the element of delayed bleeding, which can happen when ATRA is introduced, and it can harm something called etosis in APL, and etosis is a form of cell death. It's not apoptosis and necrosis, and it's quite unique to APL in that it releases nuclear chromatin, and these are organized into nets. The nets then cause endothelial cell damage and activate the coagulation cascade. This triggers intracranial bleeding, alveolar hemorrhage, and differentiation syndrome. ATRA-induced etosis may cause the delayed bleeding phenotype. In terms of the thrombosis, the main culprits are tissue factor and cancer procoagulants, and these are expressed on APL cells. They result in activation of coagulation, and thrombin is increased. We also have tissue. Cancer procoagulant is a protease which can directly activate factor 10 and therefore thrombin. Overexpression of various cytokines, interleukin B, interleukin 6, and tumor necrosis factor, which augment the activity of tissue factor, and PI1 are also present. Tumor necrosis factor downregulates thrombomodulin, and recombinant thrombomodulin has been used in Japan to mitigate the hypercoagulability seen in APL. So this is a diagram which just shows us the balance between the activation of coagulation and the fibrinolytic system. So we can see fibrinolytic system far exceeds the activation of coagulation, and this is mostly due to the Nexin 2. In this diagram, we can see all the factors that are responsible for the clotting in APL, and this is the factor 7A and tissue factor, the inflammatory cytokines like tumor necrosis alpha, interleukin 1 beta, non-specific proteases, elastase, the fibrinolytic inhibitors, and tumor microparticles. There is a difference between DIC and APL, and in DIC, interleukin 1 and tumor necrosis factor lead to the upregulation of tissue factor. There's consumption of coagulation factors, platelets, and physiological anticoagulants. There's widespread microvascular thrombosis, and there's increased thrombin generation with secondary fibrinolysis, which causes the bleeding. In APL, the microvascular thrombosis is very uncommon, and primary fibrinolysis and hyperfibrinolysis are the predominant pathologies. Low platelet count is due to the marrow invasion. Anticoagulants are preserved, lower fibrinogen levels are present, and higher levels of D-dimers are present. So in this diagram or table, we can see the major differences, and the fibrinogen levels in APL are much lower. The FDP and D-dimers are much higher, and antithrombin is preserved in APL. So in summary, we have in acute promyelocytic leukemia various factors that play a role in the bleeding or thrombotic phenotype of a patient. The thrombocytopenia, the abnormal promyelocyte blast, apoptosis, infection, and treatment with ATRA or arsenic trioxide through various mechanisms can cause either bleeding or thrombosis in a patient. Thank you.
Thank you, Yadia. I'm having a bit of trouble with my talk. I'm going to send it to Vernon and Yadia. I'm having trouble with my Zoom. So if I send to you now, if you can load it. right, for me, and I
Okay.
will, whilst we take some questions.
Okay.
Okay, it's sent now. If you could check for me. So,
Okay.
thank you, Yadia.
No
So
problem.
I don't see there's any questions. So understanding the coagulation its own can be quite complex for many of us, and actually trying to understand when it goes wrong in APL, I think that's where the challenge lies in managing these patients. And so, as I said, we chose this case just so that we could actually take apart a little bit the coagulation system and understand why things happen the way they do in APL. I'm just waiting. Yadia, did you get my talk?
I got it. I got it. I'm just putting it up now. Just give me a minute.
Sure. So I just want to give a little background into what I've chosen to speak about in my talk. It's just, I would say, frequently asked questions or things that I find and I continue to find actually over the years in managing APL patients, because no single patient is going to do what the previous patient did. And, and every patient, as you could see with the two that we've presented, they are going to present different, obviously trying to understand how to manage these patients when you do not have adequate experience or resources can be a problem. And what we do find is as I said, fortunately, these two patients came from the Pietermaritzburg area, and those hospitals drained to Gray's Hospital, where there is a clinical hematologist and access to ATRA. Whereas KZN, if, for instance, if they are coming from areas like Richards Bay and there is no clinical hematologist there, and they have to be referred to the tertiary center there. And as much as the doctors do try their best, we often find that patients sometimes may succumb to the disease if not treated, adequately, or if they don't have the ATRA, it becomes a problem. So yeah, have you got my?
Yes, I've got your talk.
Are you opening?
Yeah.
Okay.
Can you see it?
No,
Can I share
can't
my
see.
screen? Okay.
Yeah, share your screen. Yeah.
Can I share my
And then
screen?
and then you can move for me when
Okay.
as we go.
Sure why it's not allowing me to share my screen here. Okay.
I don't, Vernon, I think I've shared it with you as well, if you want to try.
Charlene, it looks like
Can you see
there's
it now?
success. Yes, if you can just put it on presentation mode, you can just click on from the first slide.
Okay. Can you see it now?
Yes.
Okay. Charlene, are you ready?
Yeah, I'm prepared. I, for some reason, cannot see your slide. I cannot see your slide.
Can you see it now? Prof. Lowe, can you see it?
I can see it, yes.
Joshua, can you see it?
Yes, I can see it, Yadia.
Okay. Charlene, are you okay there?
Sorry. Okay, thanks, Yadia. I think it's the load shedding as well. I'm switching between my data and the Wi-Fi. And okay, so we can move to the next slide. So as Yadia discussed, treatment of patients with APL represents a true emergency, primarily because of the bleeding, which continues to represent a major cause of early death. So once a diagnosis is suspected on the basis of clinical findings in the peripheral blood smear, ATRA should be started as delays may be life-threatening. So part of my talk, we will we'll cover identifying and managing the side effects of therapy and how to identify and manage coagulopathy. So you can move on to the next. So I've broken it down into obviously supportive and specific, but just to remember that in APL patients, you are doing these concurrently. So some of the supportive measures that will need to be instituted obviously is fluid resuscitation, transfusions with blood platelets, FFPs or FDPs, depending what you use in your center, the need for cryoprecipitate. And as you could see with our patient, obviously the septic patient needs treatment as well. And then once you institute specific treatments like ATRA, or if you have access to arsenic trioxide, you then have to manage the complications. And once you've also, if you are using anthracyclines in your treatment, then obviously understanding a little bit about anthracyclines. But for today's talk, I will not be discussing much on anthracyclines. You can move on to the next slide. Okay, so this here was in 2009. This was a nice an approach that I found in Blood, which was subsequently, it was the ELN people, and they've subsequently modified that, and I will discuss that as well. So once you have a patient, it's important, as we said, to institute ATRA without delaying, waiting for the diagnosis, as Yadia discussed, the flow cytometry and PCR, which might take a bit of time. So if the patient has the characteristic morphology on peripheral smear, or clinically you may suspect it, because oftentimes a hypogranular variant may be a problem with confirming that on a peripheral smear. So you could start the treatment, and then actually they recommend checking FBC and DIC screens 3 or 4 times a day, but unfortunately I don't think that's something that we could sustain in the state sector. So usually in our center, we would do it on a daily basis. Leukophoresis should be avoided in patients with high white cell counts. Avoid routine lumbar puncture, avoid placement of central venous catheters, and obviously to be vigilant in diagnosing differentiation syndrome and to institute dexamethasone. They also recommend avoiding growth factors in induction, and also to give dexamethasone to higher risk patients with white cell counts more than or equal to 30 to 50,000. However, practically in our setting, we tend to start our dexamethasone when patients have white cell counts getting close to 10, because as Vernon pointed out, these patients sometimes come with really, really high white cell counts, and they become more difficult to treat at that point. So rather, we started when we see that the patient is reaching that 10. It also said here, do not obtain a bone marrow aspirin biopsy at the NADA during induction. So you can move on to the next one. So these are the newer guidelines. And again, it says here to obviously start the treatment as soon as possible. And they give targets for aim for fibrinogen of greater than 100 to 150 moles per deciliter, a platelet count of more than 30 to 50, and an INR of less than 1.5. So again, I think this was covered. So this was just a little bit of the where they've actually outlined what values. So you can move on to the next one. So how do we initiate ATRA? So usually at a standard dose of 45 milligrams per meter squared in divided doses. And it's given to resolve the coagulopathy. So that's the basis of starting it, and also to initiate induction therapy. So you could actually initiate the ATRA according to the risk stratification, as Yadi had pointed out in her talk. So for low or intermediate risk disease, ATRA can be commenced and continued for 1 to 3 days before initiating chemotherapy, provided the white cell count is not rising rapidly. And this often does happen once you start the ATRA. And chemotherapy started after 1 to 3 days of ATRA. Because the risk for differentiation syndrome, obviously in these patients, are lower. The problem arises in the patients with a high white cell count, and giving ATRA may induce further leukocytosis and exacerbate coagulopathy. So therefore, in these patients, you may have to institute the chemotherapy and start the ATRA concurrently, or stagger it by a day or so, depending on how severe the leukocytosis is. So oftentimes what we do, if the patient's actually at a base hospital and cannot get to us within the next 24 hours, oftentimes these patients are given hydroxyurea, and if ATRA can be started with dexamethasone. So the standard dose of ATRA is continued until achievement of a complete remission by peripheral blood and bone marrow criteria, as long as the patient is tolerating ATRA well. So we use the bone marrow. This is the protocol we use in our unit. Yes, yeah, they can go on. We use the risk stratification according to good, intermediate, and poor, and we start them on ATRA as indicated, and our induction is with daunorubicin, and we would do a bone marrow and a flow cytometry post-induction, and if the patient's has no MRD, then we proceed to, depending on the risk, 3 cycles of idarubicin, mitoxantrone, and idarubicin in that order. And if a patient has a high-risk disease, we actually use HiDAC, and I will explain further on as to why HiDAC was actually used in the protocols. We can move on. Sorry, Shati, if you could go back, that I forgot to mention our maintenance protocol once we've completed induction and consolidation. So after the patient's completed consolidation, the patient should be in should have a complete molecular response. And then we commence the patient on ATRA every 3 months and monthly doses of mercaptopurine and methotrexate. So mercaptopurine is given daily and methotrexate weekly. And we continue to monitor the patient's PCR and bone marrows every 6 months until we complete maintenance. So we can move on to the next one. So I put in this slide just to show them, when you read up about APL, you'll find there are different groups that have different ways of doing things, and you will find that the development in the treatment of APL, a lot of work was done by the Europeans, the Spanish, and the Italians, and so that's just a little bit on how the treatment strategies developed. Can move on. So as you see, that the protocol we use may differ from other places. So in your center, you may use something different. So here we've got a regimen here where there's ATRA plus idarubicin for induction, and then there's another one where you could use arsenic and ATRA, and I'll speak a little bit more about how arsenic was actually introduced and the utility now in the treatment of APL. We can move on. So arsenic trioxide is an old drug, and it seems that the Chinese were the ones that actually started investigating it first, and it really has made management of APL at least a chemo-free disease to manage. So there are a lot of trials, and we can go on. I think I mentioned them a little later.
Hello.
So, hi. Oh, somebody has their unmuted, so they're saying hello to me, sorry. So just going on to a little bit on the complications of treatment. So APL differentiation syndrome is an important condition to be able to identify, and we see it both with arsenic and ATRA. And it can be mistaken for fluid overload, pleural effusions, or pneumonia. And as well as in our case, diffuse alveolar hemorrhage may also give you a similar sort of clinical picture. So obviously, it may not always be as easy to identify, but if you do suspect it, institution of dexamethasone at 10 milligrams twice daily is advocated. Patients presenting with significant leukocytosis, so those that present with white cell counts more than 30, prophylactic corticosteroids are strongly considered, provided there are no major contraindications, as we know, because they will have fatal complications. It may be best not to necessarily wait for a chest X-ray to become abnormal. So based on your clinical suspicion, you could institute the steroids. If the symptoms or signs are severe, the atra or arsenic should be discontinued and resumed when signs and symptoms have resolved, but under the cover of steroids, as this could recur. So we could move on. Yeah, they can move to the next slide.
There's nothing going to the next slide.
It's not. Oh.
No.
Oh heavens.
Ending here.
So the whole thing didn't come. Okay, so okay.
Here we go.
Oh,
here we go.
Okay. So some of the side effects of atra, which are important to note, because these are things we actually patients will complain of them: dry skin, will complain of cheilitis. You might note that you have liver dysfunction. Some of the other manifestations could be things like bone necrosis, pancreatitis, and hypocalcemia, hyperlipidemia, bone pain, headache, fever, and pseudotumor cerebri. So this is also an important side effect to watch out for patients complaining of severe headaches. So these this is usually maybe a few days after commencing atra, patients might complain of headache, and important to actually exclude the diagnosis. Things like sweet syndrome can occur, and scrotal ulceration. So this is a rare side effect, but we've seen it in a few patients, and it can be quite dramatic because it can actually lead to Fournier's gangrene, and the neutropenia that's associated with treating acute leukemia patients may perpetuate the problem. And once this does occur, or you note patient is having these scrotal lesions, to actually get start antibiotics and get the urologist involved in managing the patient. So we can move on. This is just a picture. I've never seen a sweet syndrome in a patient that has been treated with atra, but this is what it looks like. And the skin biopsy actually shows all the neutrophils and mononuclear cells that were taken from this biopsy. So this is also an interesting a complication that could occur on patients with atra. So we can move on. So with regards to arsenic trioxide, I'm not going to actually go into detail about it, but when you do your reading, you'll find that a lot of the work, as I said, was done by the Chinese, and then later on by the Spanish and the German groups. And what they found was that arsenic plus atra without chemotherapy actually was non-inferior to chemotherapy and atra. The problem lies in patients with high-risk disease and those that have a high white cell count, obviously the risk for differentiation syndrome. So here the role of using arsenic and atra as an induction will be problematic. Can we move to the next slide? So this, arsenic trioxide is actually used as induction and as in consolidation. I've come across a few different protocols, so I'm not advocating any specific one because I have no experience actually using it in consolidation. We've used arsenic in a patient or two before, and it was as a bridge to a transplant. So one was an auto and one was an allo. So I do not have experience actually treating patients, with any sort of consolidation regimen as such. So we can move on to the next slide. So when compared to the use of chemotherapy, arsenic is associated with significantly less myelosuppression and fewer infections. However, it may affect liver function, and you might find patients having raised liver enzymes. And the QT prolongation is actually an important side effect, which must be monitored. So once you have a patient that you want to put onto arsenic trioxide, actually get a baseline cardiac assessment and ECG, and then regularly monitor the ECG for side effects. A lot of these side effects are actually manageable and were reversible once the drug was stopped, and may be reinstituted with some dose adjustments. We move on to the next slide. So there are some recommendations which I've put in here, and I'm not going to go into detail, but it actually describes how to go about monitoring a patient once you've started a patient on arsenic trioxide. And it mentions the careful monitoring of the QTC interval, the QTC and the QTC. And so we can move on for the interest of time. Then going on to hemorrhage. So as we mentioned previously in the first slides in the ELN guidelines, they mentioned to actually regularly check the coagulation screen and FBC. I guess it would probably be standard practice in most of the hospitals in South Africa that you would just do it once a day. And obviously then based on that, to offer aggressive correction of whatever abnormality it is. So if the patient has low platelets, to transfuse platelets, blood. Can we just move on? Yeah, there are things on the next slide. Yeah, so usually in our center, we have access to freeze-dried plasma. So we would use that. That's readily available. And we may use cryoprecipitate depending on the fibrinogen level and platelets. Recently, we've had a huge challenge. I'm sure it's a national challenge with platelets. So to order it in advance, if we know the patient's going to need it. So we tend to now have to order them much earlier. So we can move on. Okay, we can skip this one. So an important thing is to avoid bleeding. So where possible, do not insert central lines, and just to have a good peripheral access with a wide bore cannula would be a better option in these patients in early on. And once the coagulopathy is stabilized, and if the patient then needs a central line, to consider it at that point, but early on it can create problems. Lumbar punctures should be avoided, and this especially that if you read some of the literature on the patients presenting with high white cell counts, yeah, they also mention that they have a higher risk for CNS disease, but it's not advocated to actually do the lumbar puncture early on. So can we move on? So prophylaxis to prevent hemorrhage. Based on some of the anecdotal case reports of fatal thrombotic complications in the use with using antifibrinolytic agents, it is not advocated that we use things like tranexamic acid routinely. But in our case, the first patient, due to the, we were supporting him with blood and platelets, but he continued to bleed. So we added the tranexamic acid after excluding any hematuria. So I'm not advocating the use of it. You would have to use your clinical discretion from patient to patient. So we can move on. With regards to hyperleukocytosis, the guidelines here from the ELN is to start cytoreductive chemotherapy without delay. So if we are able to get the patients to us, we would start the daunorubicin. If it's a challenge, then we would obviously start the hydroxyurea, and we would not leukophoresis these patients, and the prophylactic corticosteroid use as well. So we use dexamethasone as indicated in our protocol. Next slide. So just something about the CNS disease. So when we developed the protocol in our unit, we decided to include cytarabine in the third consolidation of our patients, high dose cytarabine, so like a HiDAC, this was to cross the blood-brain barrier in order to, if there was a potential for a CNS involvement. So if you read through some of the articles, and I've actually included some at the end of my talk, there are different people that have different approaches to this. Some people might give methotrexate, and so there's no hard and fast rule. I guess we can see what everybody else does in the other centers. So can we move on? So thrombosis, with regards to thrombosis, arterial and venous thrombosis is a more commonly appreciated than previously thought, because we always thought, APL patients are going to bleed, but it can occur in a variety of organ systems. For example, in our patient with the PE and then the splenic infarct. So paradoxically, whilst ATRA favors the rapid resolution of coagulopathy, it may also increase thrombotic risk due to the exacerbation of the procoagulant state associated with the development of differentiation syndrome. So attempts to attenuate thrombohemorrhagic risk with heparin, tranexamic acid, or anticoagulant or antifibrinolytic therapy has been disappointing. And it's actually, you will not find this in any sort of protocol or a guideline. And I guess more work is needed on this. If we can move on. So if you are faced with a patient with thrombosis, for example, a patient with a stroke, or a patient like ours with a pulmonary embolism, you are actually faced with a problem, because here you have a patient that might have low platelets. You cannot get platelets readily in order to increase the platelet counts to a safe enough level to give the enoxaparin, which we use in our center. So it is a bit of a challenge. However, one of the suggestions here, this was from the ELN guideline, was to use low molecular weight heparin according to the platelet count. So 70 to 80% of the dose if the platelets at 70, 50% if it's 50, and stop if it's less than 30. So, obviously this is from patient to patient, and there's no standard protocol, but it has to be used with caution. When a catheter-related thrombosis, Yada, can you go back to that one? Just to mention, we have a patient now with a catheter-related thrombosis. It's recommended that the catheter be removed as soon as possible. So just to, if you had to, the patient that we are talking about was an older patient that came in with renal failure, which probably was not related to the APL in any way, and we needed to dialyze her, and she then now has developed a catheter-related thrombosis. So it can be a problem. Next slide. I think I'm coming to the end. So basically, I've put in these were, it's a very nice some of the recommendations from the ELN, and it just gives us, we can just skip all of this. It basically gives us guidance as to, how to use the different agents. It speaks on the induction, consolidation, and maintenance. I just want to mention, so we spoke about ATRA. The Spanish group omits, sorry, not ATRA, cytarabine from both induction and consolidation, and they've shown good outcomes. The German group, however, they favored the use of Ara-C. And so you can see, as I said, there are different people do different things. And some of there's something here on idarubicin may cause a longer aplasia in some patients. And then with regards to, this question is often asked when patients are actually, when our patients go to ICU, about whether they can use growth factors, and it's recommended that growth factors are not routinely administered in these patients with APL. So next slide. Then it speaks on consolidation therapy. So obviously this is depending what you are using. They've given the recommendations for using 4 courses of arsenic trioxide as a consolidation. Anyway, can we move on? Just want to see this. I think we've come to the last few, and then management after consolidation. So with regards to patients that do not respond to initial therapy and who may require, for example, in our center, if we have to use arsenic, the endpoint is to take them to a transplant, be it an autologous, or if there's a sibling donor, depending on the type of cytogenetics, then an allogeneic transplant could be used in these patients that fail to reach remission. So obviously these patients need to attain a remission before you move them to transplant. The next slide. See, we've got 10 minutes. I think we can, yeah, they're gonna move, see what's left in my time.
I'm trying. Okay. Yeah.
Okay, so that speaks a bit about relapses, and we can move on. I think this may be the last slide. I think I'm going to stop here. Oh, they also speak about children. So apparently in children, the dose can be reduced to 25 milligrams per meter squared in the pediatric population. But what was found is when this dose reduction was done in adult patients, for whatever reason, be it the side effects, that the remission attained was not as good. So I'd like to end here. Basically, the take-home message here, sorry, I rushed through as much as I could at the end, is to a better knowledge of prognostic factors and pathogenetic mechanisms of the 2 phases of coagulopathy, that is bleeding and thrombosis, is crucial in the management and outcomes of these life-threatening complications. Yadi, the next slide. So I've put in a few of the references, which these are actually, there's a lot of information in it, very useful information. And the last slide, Yadi, I just want to show everyone my last slide before I end, and then we can take some questions.
Okay. For some reason, it's just
not moving. Okay, so
this is not your last slide.
No, it was a fun slide, so we can leave that out. So, so
thanks, Charlene. This was really fantastic, and thank you to your team as well for excellent presentations. I see there are quite a few comments in the chat box, and maybe I can ask you to have a quick look at that. While you're doing that, can I perhaps, yes.
Can I ask you to read out because my Wi-Fi dropped, and then I lost all the whole chat, right. So I do not see anything in mine.
100%. I will do it in a moment.
Okay.
That's no problem. Before we get to that, I just quickly asked Prof. Berg in the chat box to give us a few comments on the UCT study on APL and our experiences. Estelle, are you ready to say a few words?
Yeah, I can quickly say a few things. As people may know, we did publish 2 years ago, and Rory Shane, who's now at HemePath, was the first author. I think we found that when people get to us, in other words, when they don't develop these absolutely catastrophic DIC complications, such as if I think of our series, intracranial sort of a thrombosis, you don't always know if it's thrombosis or bleeding. If they don't develop these catastrophic complications, we found that patients actually did quite well. We had 83% long-term survival of those who did not develop these things. And actually, we did have only, overall survival was 76%. So there were, in our case, early death rates that were 7% and 13% at 7 and 30 days. So it's truly something we can be thankful for. But since COVID came, we have seen that there are many more patients that actually were left at first base, if I can call it that. People who were presenting late in other hospitals, it was too late to do anything for them. So I think COVID has impacted these patients terribly. I heard the same thing from my colleagues at Barra. The colleagues in the lab also told me that. And then I think APL remains a perennial favorite. And thank you so much, KZN team. I think we must get the UFS team to speak to us later this year about their results. Over from me.
Yeah, on that note, I now realize that Free State in Jock's mouth has left a whole lot of comments. So Jock, I don't know if you want to just quickly highlight a few of the points you were making, because some very, very interesting commentary in the chat box by Jock Malherbe, Head of Clinical Hematology in the Free State. Jock?
Thanks, Vernon. I hope you can hear me. There's probably a lot of noise in the
Yes.
background. There's a generator
we hear
running close by.
no noise.
Okay, excellent.
Sounds good.
Yeah, so I mean, I've always been fascinated by APL and this. I mean, just maybe to add on to Estelle's comment, we're also publishing our APL data in SAGO. It's accepted for publication, but not published yet. And our early death rate was actually quite high. I don't have the figures with me, but it was approaching 30% early death rate. But the survival after that 30 days is excellent. So we've probably got higher early death rates compared to the UCT experience. And yeah.
A quick note from my side, your work is very detailed and lovely regarding, lab times and all that kind of thing. So I think it's going to be great. I do think we should speak about it later in the year. So
we can definitely do so. And maybe just something on early death rate is that I always thought that access to ATO will decrease early deaths. And I actually asked that question of Prof. Sans at last year's HemOnc, and he noted that they did not note a decrease in early death rate with the introduction of ATO in their treatment protocol. So I just thought that was an interesting point, and that the most important aspect is still early initiation of ATRA. And I remember previously attending a talk from I can't remember his name, but the prof from MD Anderson in Texas, and he actually stated that they have ATRA available in their primary healthcare settings, and that it's initiated at primary healthcare level at the earliest suspicion, and they showed their survival curves, and it is, I can't remember exactly, but it's over significantly over 90% overall survival. So I think, and that's maybe where in our setting we can look at early pickup and training of especially technologists who are often in the district's setting, the first ones looking at these smears, and if they can recognize an APL and initiate that urgent referral, we could possibly improve our early death rate, and maybe also look at having ATRA available at earlier ports of call. And then just something very interesting. We also recently had, and I want to give credit to Dr. Haupt, who gave a a brilliant talk on the details of APL coagulopathy. And one of the interesting things that came out was that there seems to also be an element of blood-brain barrier breakdown, which contribute to the increased incidence of intracranial hemorrhage. And I forget the details now, but PDGFR alpha is involved in this process. And this opens the intriguing possibility of using imatinib to limit this process. And actually, she shared some studies that looked at this in the setting of fibrinolysis in acute ischemic stroke. And there is some phase 2 data showing that the use of imatinib in conjunction with fibrinolytic therapy leads to decreased hemorrhagic complications. So, I mean, we were just wondering about, we couldn't find anything specific in the setting of APL, but this could potentially be very interesting. Yeah, I mean, thinking that there's a significant increase in primary hyperfibrinolysis in APL, and if this pathway could be targeted, it may be of benefit. And I mean, we've seen a few, I mean, I can specifically remember a few low-risk patients which come in quite well, and then they just suddenly die of massive intracranial hemorrhage despite really optimal supportive therapy. And yeah, it's just, I think the coagulopathy of APL is and shown by the excellent talk so far, just much more than just a standard DIC, and there's much more going on, and there's probably some targets there that one could look at. I think I've covered all.
Thank you, Jacques. Those are great comments. Appreciate it. Very interesting. And yes,
I just wanted to say, so the thing about mixing it with olive oil. So
yes,
we
please,
had a
that was very
challenge
interesting.
because, yeah, so the pharmacist, I looked up a few things, and there were a whole lot of these oils that could be used, but our pharmacy didn't have any access to that. So I asked them, so I found this, one of these NHS protocols, and it spoke about the use of olive oil. So I brought my olive oil from home. So our pharmacist said, because they cannot trust the chain of the supply chain, we had to mix it ourselves. So between myself and our new fellow, we had to, it was quite a challenge cutting those capsules and mixing, but we managed. But it's a minute amount of actually gel inside that capsule. So it's quite a process, and I wish there was an IV form of it. But yeah, that was another aspect of the management of this first patient.
Charlene, perhaps a last question and a very interesting comment here from Yaglin Naidu. Thanks, Yaglin. He says, thank you for the talk. I'm interested in any comment on allowing patients to consume carotenoid-rich vegetables and the use of ATRA in patients with APML. Patients have this tendency to change to a very healthy diet overnight. Once diagnosed with cancer, with access to the internet, carrot juice might be consumed in vast quantities. So do you think the carotenoids will help, or will they interfere with ATRA when used in large quantities? What do you think?
I think it may. I'm not certain, but I guess there are a few things I've read about vitamins interacting with ATRA, but I'm just wondering how much of carotenoids do you have to, is he referring to having carotenoids to actually treat the APL, or the effect that it has on the drug?
No, the dietary intake of carotenoids in large quantities, and whether it will interfere with the treatment.
I guess it may, theoretically. I don't know, Yaglin. I'm not certain. Maybe Vernon, if you have some insight, but I know that vitamins do affect ATRA.
I think it's difficult to say, Yaglin. Theoretically, it does make sense that there could be some interference. My limited knowledge is that there's about 600 carotenoids. The ones well known to us, like beta carotene and alpha carotene, are, as a matter of fact, not the most potent ones. There are other carotenoids that are up to 10,000 times more potent in vitro than the well-known carotenoids. So whether they're going to interfere here is very, very difficult to say. So we'll have to go and see whether anybody has published anything on it. And I think a good start would be just to go and look at drug-drug interactions between high-dose vitamin A and ATRA. And I would not be surprised if there is an effect, because there were some studies I remember from quite a while back where they used vitamin A as part of a multivitamin combination to try and treat MDS and some cancers, at least in vitro. So could potentially be effects. Nice question. We've reached the end of our time together. What a thought-provoking set of comments, wonderful presentations. Thank you very much to the whole UKZN team and Charlene, who co-chaired the session. This is really wonderful. Thank you for the effort put into preparing this. And we look forward to having everyone back next week.
Thank you.
With that, have a lovely evening, everyone. Safe driving home for those who are still at work. And we'll see each other again on Monday. Thanks.
Thank you.
Bye-bye.
Bye.